So you've just torn your ACL, or you think you did. You went to go get imaging, and they in fact told you you have torn your ACL. So today, we're going to go ahead and talk about some basic guidelines for you if you have torn your ACL, and how to understand whether or not you might be on the right track and going in the right direction towards becoming the whole version of you again. Pre, post surgery, all of that. We're going to talk about it with our two experts here, Tommy and Rich. We're going to dive right into it. Athletes just torn their ACL. They went to go get imaging, and yeah, it is in fact a torn ACL. What do they do right from that moment once they've, maybe they don't have a surgery date booked, maybe it's in the future. Can they do anything pre-surgery?
Yeah, pre-op phase is a critical phase for them. It's the phase where we're trying to get as much strength back, barring we can get the swelling down and we can calm the joint down, and they can get as much range of motion down, or as much range of motion back as much as possible. This is where we maximize as much function before we go straight into surgery. I know sometimes everyone wants to get surgery fast, but we actually have better outcomes if they're able to get all these things back, before they do the surgery. So just focusing on trying to mitigate as much, damage as much as possible with the joint, normalize gait, get back, knee, quad strength, hamstring strength, if possible, getting it back to 90% of the contralateral side as much as possible. Also, just staying in the mode of being active, right? So that's core strengthening, upper body strengthening, just still going to the gym as much as possible, as soon as they can get off of crutches and whatnot, if they can weight bear. And yeah, just tell them about what the rehab process is going to look like, right? So that's amazing. A key phase. People think, to just sit and wait for the surgery to come, but then they get very stiff. And when you go into surgery very stiff, really weak knees, that bar or that standard now is just so low, it's dipped so low that you have to now work your way all the way back up. It's better to keep it as high as possible.
So does it make your rehab longer if that's what happens?
Correct. So you can just look at it like a timeline, right? You look at it like a graph or a timeline. So in terms of injury, yeah, you get a dip because you obviously need to rest a little bit, right? But if you keep resting, it's just going to go down, right? And you have to catch back up to where you were before. So now that peak, that path is just longer. Versus if you drop a little bit, you start to go up even a little bit more. Now you have that surgery. It's a much shorter path for them to get back to where they were before. So
are there any typical movements that should be avoided in this pre-op phase?
For sure. So basically the ACL, just talking about biomechanics of it, it kind of protects the joint in terms of, twisting, pivoting, that kind of stuff. So those kind of loading movements, you typically avoid staying away from them. Much of plyometrics and stuff like that. And if it's not in a very controlled manner, and you will know pretty much right away if the knee gets swollen the next day, you kind of stay away from it. Playing, just try and stay away from it, because you don't want to get in positions where you could potentially get a knee dislocation because the ACL is not there, right?
I think it's also important to say that, a lot of the population that we see, yes, is very athletic, but there is the non-high performing athlete that could potentially tear their ACL. And some research does just say that, you don't need technically a surgery to be able to live still a healthy, active lifestyle if we do the rehab correctly. So that's obviously dependent on the situation with, are you a high performing athlete or are you a general population? Do you have time to take that much time off of work post-op and different things like that? So I think that's a crucial part as well, is that everybody kind of thinks it's torn, I should get surgery. And there's a fair amount of research out there that suggests outcomes aren't that different.
Yeah, there's some spontaneous healing that does happen with a certain amount of population, but more research obviously needs to be done. I read the study too as well, but it's kind of interesting. The body's very fascinating how it heals. We always thought that if it's torn, completely done. Tommy, that's a great point. And then we move on to phase one. Tommy, you want to talk about phase one?
Yeah. So it's important to say that now. Let's say you have had surgery, and these are kind of the phases that we follow. Everybody has their own different types of protocols. Ours is, we just call it phase 1 through 5, basically from first day post-op all the way to return to play. So phase 1 is pretty simple. Generally, a lot of patients sometimes even question or maybe get confused as to like, hey, I just had surgery. I should probably stay at home until, things start to heal a little bit more. Ideally, phase 1 is surgical date to 14 days. So within 2 weeks, we'd want you in the clinic. And within those 2 weeks, we have some baseline goals. It's important to say also that these goals, it's okay if we don't hit them within 2 weeks.
Right.
We're going to have progressions. We're going to have regressions throughout the next 9 to 12 months of rehab.
You're also just going to have people living life and not being able to do do it for whatever reason, right?
Exactly. And the other part is also like, we are not cheap interventions, and like 2 to 3 times a week coming in to see a practitioner doesn't always like make sense for people financially if, you know, you blow through your insurance quite quickly. Having that discussion pre-op, but also having that discussion, you know, sometimes you only see the patient after they've done the surgery. So the first phase is a ton of education, a ton of making people understand that this is a process. There's going to be highs, there's going to be lows, there's going to be a roller coaster ride for the next 9 to 12 months. We want to meet our guidelines and we won't move forward until we do, but the timeline is ideal, but not mandatory, let's say.
Right. For sure.
So in first 2 weeks, you know, we'd love to see full knee extension, range of motion. We'd love to get that back as soon as possible.
It's most important.
We'd love to have good quad control. You know, we don't want to minimize pain and swelling at that point. There's still not a ton we can do that, you know, you just had surgery, but we're trying to just minimize that. We're trying to, you know, normalize gait patterns with and without crutches. So moving from 2 crutches to 1 crutch within the first week. And then really we're trying to limit idle time. Like, we don't want you hanging out with your knee just fully extended doing nothing for 20 to 30 minutes or 30 to 60 minutes throughout the day. Whereas a lot of people would think, hey, I just had surgery. I should chill on the couch. Just give it a couple weeks. So we're actively getting you moving as soon as we can, basically. As soon as you walk through the door, we're trying to already start this process, give you a bunch of different hip exercises to keep that going. The biggest thing is quad atrophy.
How do you,
I think
is that something you can tackle within the first 14 days? And if so, how?
you definitely can. There's treatment, like we can attack it with our like modalities in that way, or, you know,
Like
you can
stim?
use, yeah, exactly. You can
Okay.
use Russian stim. We can acu the quads at the same time. We're staying away from the scarring area, but
Right. But you're
there's
not
definitely
directly like training it, quote unquote. You're using.
not yet. Not in the first
Okay.
2 weeks.
Yeah,
Yeah.
perfect. Yeah, that's really what I wanted to understand. Okay, awesome. All right, so I'm putting air quotations around this 2 weeks, right? So end of phase 1. What are the goals for phase 1 that allow you to understand whether or not you guys can move on?
Yeah, that's a good question. We have criteria of progression. The criteria of progression after phase 1 is generally like a 20 degree straight leg raise with no lag of the quad. So we don't want the foot dropping when you're going into 20 degrees of straight leg raise. If there's any drop where you have no quad control, that, you know, you fail that progression.
Forgive me, that's 20 degrees through the hip. So,
So,
talking hip
so a straight
flexion.
leg raise,
Yeah.
raise, we'd want
Yeah.
20 degrees without the actual quad giving out,
Yeah, makes sense.
the
And
hip.
we're seated upright for this, laying down.
laying down.
Lean down.
Laying down.
Yeah.
Cool.
Yeah. We want normal gait, ideally. Ideally, we want normal walking pattern. And then, you know, ideally, you're not walking with a crutch or an immobilizer. That's a part of normal gait. And then range of motion, we like 110 degrees of active flexion and extension with no more than 5-degree difference between the 2 limbs, basically. Yeah, that would be our criteria for phase, you know, to get through phase 1, which is realistic for the timeline.
Right, for sure. Obviously, barring any complications or anything like that, because
Complications is also
Again,
the
yeah,
part
that-
of, you know,
yeah,
was the meniscus involved? There's, you know, there's different aspects of this, of course, what kind of graft was used, but these are
Mhm.
just base guidelines. Yeah, for sure.
yeah, for sure. Makes sense. Absolutely. Yeah, and I just
Yeah.
want to preface all of this by saying none
This
of this is necessarily advice that you need to follow yourself.
Yes, this is
It's
our
more if you've had
way
an
that we're
ACL
doing it,
injury,
yeah.
it's more just for you to understand the general timeline of the way things go. Understanding, of course, that like the rehab is going according to plan. There's
Yeah.
a whole host of factors that might, you know, shift that timeline or even shift what you do. And the biggest thing is, you know, like these guys, work with professionals in person, because there is no online ACL rehab program that you're going to do that's going to be better than getting direct feedback from a physical therapist, chiro, physio, whatever, whoever you're working with. There's nothing that's going to be better than getting that direct feedback, because then every time something happens that goes according to plan or doesn't, you have someone qualified to understand what's going on.
You know, past the phase 1, which is what Tommy described, which, you know, great point, like different approaches, different grafts, different, like if there's meniscus, then your weight bearing restrictions are definitely going to be there. You know, you might not be weight bearing for up to 4 weeks. So it really depends on the person. But usually after, when we start to get to like phase 2, when range of motion is getting a little bit better, we want to continue to try and protect the graft as much as possible. It's going through a whole dynamic change into like, from a tendon, trying to basically heal within the bone itself, because it does have to mature within the bone. So we're not trying to put undue stress on it. And so we're just trying to get, that full range of motion back and start to load up some of the muscles around the joint, right? So it can start off with just the hips, trying to do like leg raises, sideline abduction, or getting into like glute bridges, all that kind of stuff, and starting to train generally hip first, I like to say, and then trying to train at the ankle in terms of like calf raises, and trying to progress over to doing it controlled, going over to 1 foot calf raise, and then start to load up the knee a little bit more in the range of motion that you've just acquired, whether that's a wall sit, whether that's ball squats, where you have a stability ball behind you and you're trying to drop down to as much as you can, obviously with comfortable range. We still got to understand there's probably going to still be some swelling in the knee joint, which is going to restrict how much range of motion you're probably going to get. Like Tommy said, about 5 degrees to the opposite side if you can. I find a lot of the times there's still swelling that even lingers up to 1 to 2 months, depending on the person. I also want to just go over a couple of things during this phase. Like, we deal with different athletes. If we're dealing with someone who's a soccer player at OPDL or something like that, right, in their 14, 15, I don't have to have this conversation with them. But if we're dealing with professional athletes, I tell them, mind your drinking, get your sleep, right? All of that kind of stuff you're gonna see it, because they're gonna have more swelling, they're gonna have more pain, they're gonna have everything that's gonna be exacerbated. So I let them know, like, as we're going into the phase 2 and we're starting to load up a little bit more, we got to be able to listen to the body. And if your body's telling you have more pain because you're doing all this kind of stuff on the weekend, we're going to be holding ourselves back, because, I'm not going to force you to go into, too much pain. Sidebar, Neymar's rehab was crazy, by the way.
What happened?
They were doing straight up just
torturing the boy,
plier,
torturing,
wrenching the knee, trying to get the knee flexion back. I'm like,
that was a big thing on social media where a lot of people were losing their mind on it.
Yeah,
really?
That's not, it shouldn't be like that. I always tell people, like, your body's going to tell you how much you're doing and what's too much. And we will know what's too much as well. That's why the professional eyes will tell you what's too much. And so, yeah, we're just trying to get back as much, strength as possible at this phase. Also working on proprioception, balance. So that's like single leg balance, tandem steps, step overs, that kind of stuff, normalizing the gait, because all of that's important. Yeah. So I guess like goals going from phase 2 to phase 3, we're talking about just creating proper movement patterns. That's whether that's the squat, the deadlift movement, the bridge patterns, just loading up the knee in a certain kind of way. Before we start to load up any kind of weight, you're just doing body weight at this point, or even sometimes just TRX, holding on to a TRX and doing it. So just getting that movement pattern down. So it's just neuromuscular control at this point.
What are you looking for before
what that means,
progression?
Yeah, so that means just quality of movement, right?
Okay,
can you
quality?
Can you squat with the right patterns without you leaning over to one side? We don't want to load too quickly, because I always say the body likes to take the easiest pathway down, right? Which is what's the least painful, right? It's gonna start to veer off to one side.
Especially elite athletes are incredible at compensating and then still being able to produce that,
making it look good.
Exactly.
Yeah.
And so they're like, look, I'm doing it. Like, no, you're not. You know what I mean? That's where you get the
And I want to caveat all of this with saying, if you had the technology, right, in every clinic or whatever, for something like that, to assess movement quality, you probably use false plates, right? Because they could tell you directly how much force they're producing on each side, stuff like that, right?
Exactly.
But if you don't, you set up a video camera, coach's eyes or therapist's eyes, and that's how you're assessing that stuff.
Yeah, right. And at this point, some people will throw in, depending on the clinic that you're at, like blood flow restriction training and, just other fancy little gadgets that you have in there. People still use NMES, or basically neuromuscular e-stim, to basically just get some more activation back into this at this point. So they'll do squats with the stim on, that kind of stuff.
So side note about VFR, just because we use it a lot with our athletes, I think one of the things Tommy mentioned was just muscle atrophy, right? So that's part of the reason you would want to use BFR, is to build that balance back up.
Hypertrophy, yeah, because hypertrophy is basically trying to fatigue the muscle as much as possible, right? So if you can get it to fatigue and get it to a stress metabolic state where you're fatiguing the muscle, and that's whether those factors are in the tissue itself, that creates the stimulus for growth, muscle growth. That's what BFR does. It just kind of traps the metabolites in the area. And that will get you your hypertrophy a little bit quicker at that stage.
And for reference, for those who don't know,
less-
BFR is used when you don't have the ability to provide mechanical or high level
Stress.
of mechanical stress, because obviously the joint is weaker and you don't want to do that. That's where you would use BFR. You do a bunch of reps and you get muscle hypertrophy via the metabolic pathway as opposed to mechanical stress.
Yeah, because
You don't use it doing bicep curls in the gym?
I definitely do, for the same reason.
But yeah, I just want to stress, like, protecting the graft is number one. You know, it's an expensive graft. It's an expensive procedure. Everybody's involved. We don't want to mess it up, you know? So BFR at that stage, you know, it makes sense to not try and load up too much. Also want to caveat and say, like, not a lot of physios. I think we're going into a more progressive realm in physiotherapy, but leg extensions. There is a big kind of like, let's stay away from leg extensions because leg extensions put undue load and stress on the ACL. And there was a couple of studies that showed that walking produces just as much, if not more, load on the ACL, than just doing a leg extension. But that's obviously like appropriately loaded. You're not going to go body weight right away, but you can start to do something.
Like body weight on the machine.
Leg extension, yeah.
Yeah, like if you weigh 180, you're not putting 180 on there. You're probably putting like 30, 40 pounds on there to begin with, right?
Yeah, very minimal. And then you want to also make sure that you're within a certain range. So at higher ranges, or basically closer to 0 degrees, you have more stress. So if you just keep in between like 90 and 60 degrees, you're able to start to load up the quad a little bit, because leg extensions are probably the best exercise for quad general, right?
Right.
So
well, bodybuilders would agree.
Yeah. So waiting too long, you know, it's probably doing more. It's just lengthening. I'm not saying it's doing more damage than good, but it's just going to be, you're going to now wait for a little bit longer for them to start to have that movement pattern down. That means more time that the quad's going to have to get back up there, right?
I would actually agree that it's going to make it worse. You wait too long to load it, because if you're waiting, what you're also doing is those neural pathways for that kind of muscle contraction, you're losing them as you don't train them. So if you are waiting for too long, or you're resting, and obviously on the guidance of your therapist, loading it, then I would say that you're actually getting worse, because not only is it going to be harder to get back to, but like your literal those neural pathways are going to be affected. So you got to make sure that you're trying to get it back as soon as you can. Yeah. So now we've done with phase 2 in terms of understanding what we need from it. Is there a general sort of timeline that you guys have seen, or is it something that is completely dependent and there's no way to tell a timeline?
No, I think there's some kind of timeline that we want to try and follow, but at the same time, it depends on the person. So I've seen it last from like 4, like phase 2 can start at week 4 and last all the way to like week 8, all the way to 12, right? Because there's so many things that we're trying to maintain: range of motion, strength, patella, make sure the patella's moving. There's so many things that we have to try and encompass. So it might take a little bit longer than that. Yeah.
You're also going to have the I go really hard patient, and you're going to have the I haven't been doing my homework patient. And so, I mean, we have guidelines for sure, but like we said at the beginning, it's like it really depends on your subjective outcomes, really, right? And how many external factors can we control? Not that many when you're not in clinic. But so then we dive into phase 3, which again, if we talk about guidelines, it's generally we'd love for it to be week 7 to 12-ish time frame. I think one thing that Rich said earlier, which is really important, is at this point, the athlete is probably starting to get a little bit depressed. They haven't been able to do much. You're talking about people that train every day, right? And they haven't been doing much at all aside from the boring rehab that, we talk about. Phase 3 is again at the beginning where we try to talk to them about like, hey, this is the phase where like you'll start to get a little bit of joy back in your life. Ideally, we'd like to have you, if you don't already, obviously, if you're an athlete, you do. But at this point, patients getting a gym membership somewhere in this phase. Like we're starting to actively work out. We're giving you quite a bit of homework. You don't necessarily need to be coming in for the hands-on type of thing as frequently, I would say. Our goals are obviously to maintain that full range of motion that we had through phase 2. And then towards the end, we got to pass week 8 and then week 12 testing. And we'll kind of talk about that in a second here. But ideally, we'd love to have you at 7,000-ish steps a day. We want you moving, but we want those steps to be quality, not just quantity. So it's important to dive through that with the gait pattern and all that stuff. In the strength training now we're diving back into more athletic based stuff, right? So leg press, knee extensions, like you said, quad extensions, lunges and multi-directional patterns, potentially starting to dive into, some shuttle work, some side to side work, RDLs, deadlifts. That's where we're starting to get into. Yeah. Usually the patient is obviously a lot more enjoying this phase. And now we're past that phase of kind of being, not able to do what you want to do on a daily basis. Working a ton on proprioception. So a lot of wobble board, Bosu balls, stuff like that, just to get more proprioception into the leg. Cardio at this point, we watch you walking quite a bit, 7,000 steps a day. In terms of treatment on our side, really at this point, we're treating symptoms that pop up. So, it's common to have patellar tendinopathy throughout this process. Like maybe we're loading it too fast now, and then we got to treat it on our side. Posterior knee pain, hamstring pain, different things like that pops up. It's normal. This is that part of that kind of roller coaster ride that I was talking about at the beginning, where something pops up. And the important part is to make sure that patient, again, understands that, hey, like this stuff happens. And we do this all the time. It's very common because at this point, I think you're working also a little bit on the psychology side with the athlete. Like, hey, we're starting to get back into it. That doesn't mean you need to go sprint at 100 miles an hour, right? That also doesn't mean that we need to be babying this as much at this point. So if we talk about the kind of testing.
While we're talking about this phase, I guess I'll let you finish and then I'll ask some questions. But what are we able to do typically from an S&C side? Is it like, are they able to jog? Can we do some A skips and things like that? Basically not sprinting, but like start introducing some mechanics work.
This would be after the testing.
Okay. Amazing.
So you kind of you got to pass kind of what we're talking about here. And then from there, yes. So week 8 testing, again, week 8 is just a number. We're just going off ideal situations. Week 8 is like, hey, you're walking independently with normal gait. There's no pain. We're good. Circumference of the quad, we'd like that to be at least greater than 70% of the non-surgical leg by week 8. And then you need to be able to control a 10-second squat, kind of 10 seconds down. 5-second eccentric, 5-second concentric phase to about 120 degrees of knee flexion at this point. That's week 8 testing. It's a very simple test. It takes a couple minutes to do it. If you pass that, then great. Now we can start to dive into more, like I said, the more S&C side of things, the training. Here's your at-home workouts, go to the gym, do your thing. Week 12, which would be ideally 4 weeks after they pass week 8 testing and they've been doing things in the gym. At this point, now we're like ISO testing. So to talk about that briefly, if you are strength testing someone's quads with your hands, please stop doing that. The whole 1-to-5 grade ratio there's other things out there nowadays. And it doesn't have to be incredibly expensive. A tin deck for a clinic is, I think, $200 maybe. And as long as you're getting guidelines and numbers.
What's a tin deck?
So tin deck is like a dynamometer, basically a little
tension dynamometer.
Tiny little thing that you can buy online that you just tension one strap to each side. And then as you pull apart, it'll give you raw data on your actual phone. It doesn't have to be kind of like the one that you have is Dynamo, I believe.
Yeah, from Valve.
Yeah. I mean, a little bit more expensive and a little bit more premium, but even as just a small clinic, it doesn't need to be anything extravagant.
Crazy.
No, but I think a tin deck costs like $100. So
exactly.
Yep.
But if you're testing for an ACL, please use some type of raw data. Don't use your subjective opinion with your hand. It's just not the right way to do it anymore. So at that point in week 12 is our first time ISO testing. We'd love to see the quad strength on the surgical leg to be at about 80% of the non-surgical leg. So when we test for ISO quad, about 80%. Same thing for hamstring, get you face down. We'd love for that to be at about 80% of the contralateral leg. Is that always what happens? I mean, Rich can say it. Not always. Sometimes it's more. That's an ideal situation. Sometimes it's a hell of a lot less. And then you get an eye-opening conversation of what have we been doing at home, right?
Yeah.
And so that's where timelines, in my opinion, really start to gauge like, okay, we're at week 12, but our quad strength is not anywhere near where we want it to be. Yeah. So now we're going to have to regress and kind of progress from there. So that's week 12. We'd like to do ISO testing, and then, active range of motion should equal your passive range of motion within 10 degrees-ish. At this point, you should be able to do a single leg squat to 45 degrees of knee flexion without any support. And then to answer your question on kind of the S&C world, we call it the Brigham plyometrics routine, but it's a plyo routine test basically. If you're able to do this, then great. We kind of clear you into moving forward into phase 4, which is obviously more strength conditioning based. I won't dive too much into it. You can Google it. The plyos, it's being able to do 2-legged ankle hops into a single leg, timing it, and then with rest, and just being able to do the progressive reps of that without pain or discomfort or losing the ability to actually do it comfortably.
Yeah, and so before we're going on to phase 4, yeah, Tommy, you did talk about in terms of like what we see in clinic is a lot of times we don't get to that 80% ratio that we want, but that's sometimes due to just because of the surgery types, right? So like someone has a quad tendon or patella tendon graft. The knee extension, probably going to take a little bit of a battering, right? You're probably going to have tendinopathy maybe in phase 2. And if someone has a hamstring graft, you're trying to protect the graft as much as possible. So you're not doing as much hamstring loading early on in the phases. So they end up having a little bit less in terms of strength, right? So it really depends on the surgery, type of surgery. There's always a pro and a con with each one. So, we take that with a grain of salt, and sometimes we push things back, or, we keep moving forward. But in the ideal situation, yeah, we're trying to get to that 80%. And then the hop tests. So I modified the hop test anyways for just the last part in terms of single leg hops. A lot of people, I was finding with ACL anyways, a lot of people in terms of single leg hops, it was quite daunting for them to do single leg hops. So just going into it knowing that they can just start with a banded assisted hop, and then eventually having like 2-3 weeks to pass that mini hop test. That's probably the best way that I saw to approach it. And then
I think that's a great point. Actually, just to what you were saying was, this is probably the first time they're going to start loading single leg into the hop on that leg after 12 to 15 weeks of,
and then nervous.
There's like, at this point, there's a lot of psychological barriers. There's a lot of like, I don't think I'm ready. And, our job is to make sure we're gauging, are they actually ready, or is it a psychological barrier? And that's our job, to be able to push them through that and show them that it's okay. But this is that area where they're like, I don't know if I'm ready. I can still feel something in my leg. I still feel some swelling, this. So yeah, that's important to know at this phase for sure. That's a great point.
Yeah. And so we just have to manage expectations and just give a little bit of motivation for them. But yeah, when you reach to phase 4, this is where we can start some plyometrics, right? So, when I say plyometrics, everyone thinks I'm telling them to do a 40-inch box jump. No, it's, plyometrics has phases to it. So you can start, deceleration, which is just basically a progression of what they're doing in phase 3. So if they're doing lunges, like Tommy said, lunges laterally forward, now what we're doing is the entry into that lunge is just a little bit, quote unquote, quicker, if you want to call it that. They're letting gravity kind of take them into it, and they have to decelerate. So deceleration is the first phase. And you're just decelerating laterally as well. You might do some rotational deceleration as well.
Depth drops are cool.
Depth drops, that's vertical deceleration. So you can do horizontal or basically on level plane, and then you can do vertical deceleration. Start off with 2 feet, and then start to go like tandem, and then start to go single leg, and then return to run protocols. This is early on in my career. This was a phase that I used to mess up a lot. I would give return to run protocols, and it would be like every other day that they're trying to do like a run walk kind of program, right? So I start off with 1 minute of a walk, 1 minute of a quote unquote jog, and then about 5 minutes of a walk. And so I would tell them to do that for 6 cycles. Turns out to be about 20-30 minutes. And so they would do that, and I would say, okay, if you have no pain for the next day, then you could probably do again for the 3rd day. So let's say they do on Monday, rest on Tuesday, see how it feels. Wednesday to go back again. Okay, if they're feeling good, maybe you start to go on to phase 2. Now you shorten it. So you do 2 and 4. So 2-minute jog and 4-minute walk. And it cooked their knee pretty much.
How many tendinopathies are walking through the door, bro?
It cooked their
As
knee.
you were saying that, I'm like,
gosh.
I can just hear it.
Yeah.
I can hear it.
Yeah. So early on, I figured like, yeah, it's too quick, too fast. So now I just tell them, just try 2 days, separate them by 72 hours minimum, right? So you do it on a Monday, you do it on a Thursday. That's it. That's it for the first week. And then you come see me the next week. We see how it is. Okay, we do some more loading deceleration, and then you're going to do it again in the 3rd week. So I leave a full week in between to really see what the knee's doing. And then I might add a 3rd day, right? And then start to progressively, however physios or rehab people want to do it, it's got to make sense. I was just Knees were being flared up all over the place. So yeah, I take it very slow with the return to run run now. And so after this, in terms of strengthening, we are trying to get to as much as possible body weight, whether it's body weight squats, body weight deadlifts, body weight, almost everything, right? We want to try and strengthen as much as possible, make sure the knee's able to tolerate as much load. This is where we start, like I said, rotational stuff, where we start to, the ACL it's getting to heal a little bit more, so we can start to introduce some rotational stuff. One of my favorites to introduce in this phase is curtsy lunge. So you're starting to have a little bit of that tibial rotation as well. And you start off as high as possible to comfort, and then landmine curtsy squats or curtsy lunges into it. And yeah, and this is, Usama, you were talking about doing A skips, B skips, C skips, the running mechanics, right? So as they progress in their return to run, it might be on week 4, week 5, then they might be doing 3 on 3, 3 to 3, like 3-minute walk, 3-minute jog. We start to get the pattern down, right? So we want to make sure that they're also moving correctly, because that first time that when they start to jog, they're going to be limping a lot, right? And so we want to get that movement pattern down. And while we're getting that A, B, C skips, is we're preparing them for sprinting, right? So the next phase is going to be sprinting. So you have to have proper form, especially at top speed if they ever reach that, or, just getting out the block or being able to accelerate. And they need to have good hip drive, right? So they have to have good hip mechanics, all that kind of stuff. Yeah, without going too much into it, we'll probably do another quad test, hamstring test to make sure they still have that, they're getting to 90% now, right? Instead of like 80% threshold. And yeah, just more jumping.
Listen,
so one more thing.
Go ahead.
Yeah, I forgot. There is a test that we do sometimes in stage 4. Sometimes I push it to stage 5, which is going to be the hop test, the Cincinnati hop test. So there's a lot of great areas.
Am I right in thinking that not everybody loves that?
Not everybody. Yes, I was about to say. There's a gray area in physio realm where not a lot of people love it because they think that's the return to play kind of hop test. And I just use it as, it's just, you're looking at how good you can load the leg in plyos, right? So it's it's not a return to play by any means. So yeah, I just use it in that phase, and I do the cross line test. Like I said, it might be in the end of stage 4. Sometimes I leave it to stage 5 if they're not comfortable with that single leg hop yet.
Okay, I want to take it back just a little bit. Excuse me. So I want to take it back just a little bit. You mentioned obviously one of the things you want to do in this phase is being able to teach them how to decelerate properly, right?
Yeah.
And then you mentioned potentially, depending, you want to do that hop test as well.
Yeah. Also, I missed the whole gap in between there. Concentric phase, yeah.
Yeah, no. Yeah. I assume, but yeah, thank you for clarifying. More what I wanted to ask was, have you noticed deceleration mechanics change post ACL? I have, so I wanted to ask whether or not you've seen the same change.
Yes. So
can you talk a little bit about that and how you might coach that out of the athlete? Because sometimes what will happen is post ACL, a lot of athletes will utilize much more of a hip dominant strategy when they decelerate, because they're afraid to get to that kind of end range knee flexion. When they put the brakes on, I'm talking about horizontal deceleration, whether that be in a lunge or a slight jog to a deceleration, whatever it looks like, or even in those hop tests. And I've seen this myself.
Yeah.
When they do the hop test, if they haven't been coached on deceleration properly, what will end up happening, they'll hit the end of that hop test and go fully kind of hips back. Almost looks like they're folding over the knee just to avoid bending it. So at what point do you see that and coach it out of the athlete?
Yeah. So important. That's a great topic, Usama. So in terms of, I see this early on when we're trying to load in like lunges and stationary squats and stuff like that.
Right.
I'm just getting the knee over toe.
Hips back.
Yeah. You start to shoot the hip back, and they're using a lot of like hip extension in order to decelerate going forward. How I've tackled this anyways, and I remember I had a young athlete at that time. But how I did it was I got him up into a loaded knee over toe position, put some dumbbells on, and have him ISO it at the end range. You know what I mean?
Yeah, I love that.
ISOs are, I love ISOs for everything, but just get him on a 12-inch to maybe a 20-inch box, and I just got him just to load it up a little bit of weight to almost close to failure, right? 20 seconds, 30 seconds, whatever. And then over time, he got comfortable loading up or being able to tolerate tension at that joint range, right? And so that was an important part. And then we got obviously the mechanics a little bit better. And laterally, when it happens laterally as well, because they don't have tibial rotation. So the tibia has to rotate, especially when you're landing laterally. And so in that case, they shoot the hip back as well. Right. And that's where the curtsy lunges, like I said, the curtsy lunges and being able to, lunge properly and load it up where they get their hips to be facing. I tell them the headlights facing that way. Right. Yeah. There's different ways to coach, but you have to be able to see it, because to the athlete, they're going to think they're doing it. They're doing it. Coach, what do you mean? I'm doing it.
Yeah.
I'm jumping and landing, I'm jumping on the box, but you'll be able to tell and see, okay, let's take a step back a little bit and let's work on this.
Like I've seen some instances where people will do the hop test and on the affected leg, do it with horrible form. Like it looks like every hop is going to hurt them. And then the other leg looks smooth, but hey, I'm within 90% or whatever the threshold is. Yeah, but that 90% doesn't look good. If it doesn't look good, it's going to end up affecting a lot of other things after this rehab. So that's why I wanted to bring it up, because sometimes I do see poor mechanics, and I just want to make sure like that's something that's addressed, and obviously clearly it is. Right.
Yeah, for sure.
I think there's to switch it up here for a second. There's one thing that Rich said that I think is gold for the therapists that watch this or listen. He has no problem mentioning where he went wrong previously with the knee, like telling people to run a little bit too fast, and then he had those knee problems come back and flare up. I think in our world, we tend to always try to not make mistakes. And it's A-okay to be able to say, hey, I made a mistake and now I know and I learn from it. And in the therapy world, like science is always ever changing. Like people were doing things 20 years ago that now we all laugh at, and like it's okay that things change. And I think I see it also when I'm teaching in the seminar world, is that like it's okay to make a mistake as long as you look back and learn and let your ego stay at the door when you walk into the clinic. Because the problem is a lot of times you walk into a clinic and people are like, oh, 100% it's this. You just got to come see me this many times a week for whatever amount of weeks. It's like, we don't know 100% of anything. So it's okay to understand that. And like, kudos to you to even say that on a platform like this is good. It shows that like, hey, that's the way that you should be looking at it when you're in the therapeutic world.
Yeah. So Tommy, great point in terms of being able to learn from kind of like your mistakes. And, reflecting back on it now, practice is a lot smoother when you take it with a grain of salt and know that everyone's not going to be able to do stuff. And it's okay to go a little bit slower at first and assess. But yeah, after we kind of do those tests, those battery tests in terms of hop tests and looking at the quality, like Usama said, we move on to stage 6, or basically after this. And, we're looking at getting into return to play. So Usama, what are we doing here?
So it's interesting. Obviously, return to play is different for everybody. I think the biggest thing with being a performance coach is when you're looking at return to play, you kind of always have to look back at the therapist to see what's indicated and contraindicated from throughout the rehab. In some instances, a lot of the exercises that you guys have spoken about is actually something that a performance coach would handle, because in some team environments, whatever environment you're in, unless you're kind of working with a therapist in a clinic setting, a lot of the S&C stuff, the basic loading for the upper body and stuff, we're doing all of that. Deceleration mechanics and stuff like that, we're doing all of that. So typically we're involved a little earlier in the pro sport world, whereas in the clinic setting, once an athlete's ready to return to play, we're just looking at, okay, where are your deficits and where do we need to get back to? As an example of that, what I might do is get an athlete on the force plate. Right? If I know they can jump, I know they can do all of that stuff. What I'm looking at is where are the deficits on this force plate. So a couple of things I'm looking for is eccentric rate of force development. That's going to tell me how well you're decelerating and also what the difference is between the sides. We're looking at landing force as well, because just like we spoke about with those deceleration mechanics in the previous phase, the landing force is going to tell me a lot about how stiff your landing is. So as an example, if I've just hurt my knee, most athletes on the side that they've hurt their knee will try to either shift to the other side, obviously, but if they're not shifting and there is a symmetry there, they're landing with stiffer limbs because they're not trying to bend their knee quickly. So as a result, you see that landing force spike the moment that they've landed on a force plate. That's how I can tell an athlete isn't ready to handle the demands of going out there, sprinting, changing direction, all of that stuff. The first thing we need to do is work on being able to, quote unquote, quiet the landing. It's interesting, if you have access to a false plate, do it like this. Jump on the false plate and land with really stiff legs. Jump on the false plate and land, bend your knees, bend your hips, land soft, like you're trying to be quiet. You do those two things, the difference in force going through your joints is incredible. And what's interesting is when an athlete jumps, post ACL or something like that and lands really stiff, what they don't know that they're doing is more damage to their knee. Maybe not to the ACL, but definitely to the patella tendon and things like that, because we're just creating so much more force going through the knee. So deceleration is going to be the number one thing that we look at. We're also looking at making sure that your strength is adequate enough for you to handle the demands of what it is that you need to do. So if I'm looking at a football player, for example, I'm following probably more of a triphasic template where I'm focusing a lot on eccentric strength and making sure that we're doing supermax eccentrics and making sure that we can handle a bunch of eccentric load that is fast and slow. So strength and speed. We're gaining mechanics back. We're working on the first couple of steps of your sprint, initially with no deceleration. So you're just kind of jogging it off. And then eventually, once I'm happy with the deceleration in the more controlled environment, then we're working on a 1-2 step deceleration kind of in the field setting or outdoor setting or court setting, wherever you are. And then after that, we're looking at, okay, how close are, and this is where that timeline doesn't really exist and you have to throw it out the door, because there isn't a timeline for return to play, because there's so many things that play a factor into your return to play once you've been cleared to start this S&C work. So like I said,
you took the question right out of my mouth, man.
Yeah.
I was gonna be like, well, how many times do you get asked how long this is gonna take?
I don't know. It's gonna take, weeks, it's gonna take months, it's gonna be whatever. I think the one thing that we see a lot of the time on social media is, I think Stephon Diggs came back to route running really, really quickly.
Early
ACL.
I saw that.
And everybody was really worried. And, look, I'm not Stephon Diggs' DPT or performance coach. I don't know why or how they've been able to get to that point, but everybody is different. So if you're not an elite athlete that's used to coming back from injury, it might take a little bit longer.
Let's pray that our boy does well, because I picked him up in fantasy this year. Let's go.
Well, I hope he does. And you know what? Like I said, I'm not savvy to that rehab, so I'm not going to speak on whether or not it was too early. The biggest thing we want to make sure that you're doing, though, is the first time, let's say you are a receiver, the first time that you run routes, I want to make sure that prior to that session of running routes, you're able to handle the demands in a safe environment where you're not catching the ball. There's no external stimulus like a DB in front of you. There's nothing like that. It's just you and the sport-specific movement. And if you can handle that, and we take videos and it looks clean, you don't look like you're compensating, then boom, we're going to move on and we're going to start adding stimulus. But effectively, the way that we would do this return to the field or the court setting is going to be as simple as skill, drill, chaos. So those are the three things that we want to do progressively. So the first thing is, do you have the skill? Do you have the skill to complete the movements that you need to be able to complete the basic things, right? So can you do a good march, a skip, a bound, different types of bounds? Do you have good mechanics when you're at top speed, not running top speed, but do you have good top speed mechanics? Do you have the strength and all of the other stuff that I spoke about? Drill is where, in a safe environment where you know where you're going, there's no external stimulus, can we accomplish these things without any compensation, without any pain, and with it looking, kind of like how you're supposed to look? And then the chaos is the last bit. Chaos is before you get to practice or anything like that, can we emulate the chaos of that game? Can you fall down, get back up? Can you plant and cut and change direction with a stimulus in front of you? Can you do all of that stuff in this chaotic but slightly more controlled environment? Cool. Then we move on to the final bit of chaos, which is, go out there and perform your sport. But each one of those things is going to have, it might be 3 weeks, it might be 4 weeks, whatever. The biggest thing is we got to make sure that you're doing it properly without compensation and you feel like yourself again. If those three things happen at each phase, then we move on to the next one.
I think depending on the sport as well, maybe you guys can chime in on it, but like the first time somebody falls trying to return to play after an ACL rehab, it's like the anxiety and fear that they have when that happens. I've had patients in the clinic just like randomly trip because they're doing a shuffle and they I don't know, they just tripped on their foot. They fall and it's tears. I'm like, guys, like just stand up.
Yeah, or like shot.
You're okay, you know? But the fear of like it happening again is extremely high. And I think a factor that we always talk about the physical. Do you meet the guideline? Can you do the hop test, the force plates, all this? But like, are you okay to go back up here? And that's a big part of it.
And I think that's why metrics have their place in this rehab. Because if you can show an athlete or a client, hey, look, like this leg is the same as that other one. A lot of the time that does leaps and bounds to the confidence. Whereas if you're doing the manual testing or just the eye test, they can't see that. They don't know whether or not they're actually at that point. So that's where I think metrics really, they're important.
I'm going to also say as well, so one thing I learned from doing rehab and trying to take people all the way to that 9 months, and I usually don't try and discharge before 9 months, just because there's some studies out there that show before 9 months. It's a timeline. Everyone does things differently, but I usually try and keep them at least for that time. And I want to ask a question at the end as well. But towards the end stage of that, where I'm doing a lot of cutting, external perturbations, all that kind of stuff, I get them to at least watch some kind of tape that they have had, whether it's a great game, decent game, poor game, whatever it is. Just watch tape of yourself in that game. And that really helps in the confidence, because then it's almost like they're tapping in those same neurons, the mirror neurons that they've had from when they were playing, and that builds that confidence as well because they see themselves playing. But it really depends on how early you do this, right? Because if they can't do much and you're showing it to them at week 8, they're like, it's like, man, I used to be the guy. You know what I mean?
Yeah.
Versus if you're showing them towards the end range, you're like, look, you were able to do that. Like you playing it, I think you're almost ready. You know what I mean?
Yeah.
Like that's the difference. But hopefully they have some game tape and they can watch it and really reflect on and see themselves doing that. And obviously there's sports psychology and all that kind of stuff. You can send them to go see a sports psych if they have the resources. But as physios, we know we're dealing with majority average population, right? So if we can use our little tidbits of gems and research knowledge that we have here and there, it goes a long way for those people that don't have it.
I do find making general pop clients feel like pros does a lot to the confidence. Makes them feel very confident about their own ability to do things. So giving them, the same data, the same relative approaches generally tends to help. The last thing I will say on kind of the performance side is, apart from those first few weeks post-op, we're actually a little bit more involved than just kind of leaving it to the therapist. And it's because you might have injured your knee, but the rest of your body still works. And in that sense, it's the performance coaches, strength and conditioning coaches' job to, every athlete is dependent. Some athletes don't want to do anything, and you can't push them to do it. You'll just push them further away, right? But it's your job to keep them motivated to continue to work, because if you don't train other things, what's going to end up happening is they're going to return to sport months they haven't worked on the other stuff. And now all of a sudden you're seeing they're coming back into your clinic again because you've seen another injury because they forgot to train their upper body. And now they've torn their pec. Do you know what I mean? And I've seen that before. I've seen someone have a 8-week injury, knee injury, not train upper body at all. First game back, bicep tear on a tackle because they didn't want to work out. They didn't want to do anything. From that point onwards, I made it a point to basically be on my athletes about, hey, you got to make sure you're training other things. So yeah, we're going to wrap it up now. That was awesome. I learned a lot, so thank you very much for that. Obviously, again, big caveat. Make sure if you have a catastrophic injury like this, you have a catastrophic injury like this, you are working with a professional that can see you and give you feedback. That's the biggest one. Don't just listen to the advice that you find online, as ironic as this is, because this is online advice.
And this is only brief.
Exactly. Use this brief
Surface level.
Yeah. Surface level guidelines as exactly that. A guideline of, generally, if everything all being well, this is where I need to be at each stage. But remember that everybody is different. Everybody's going to have a different injury, even within the same category, and the rehab's going to be different. So work with someone in person And that's really going to be the biggest thing. Guys, really appreciate it. Thank you very much. This was So You've Just Torn Your ACL.